Uh, okay, everyone's starting to come in now. Just give it a couple of minutes until everyone's kind of made their way in. Alrighty. Just give it another 30 seconds or so, and then we'll get going. Okie dokie. All right. So welcome everyone to the learnings from integrating dental sleep medicine into my practice webinar. Bit of a different format tonight. We're going to be talking with Dr. Hugh Fleming, Dr. Alex McDonald, and Dr. Rohit. I'm not going to have a full crack at your last name, mate. Sorry about that. The way that we're going to run this one tonight will be more of a Q&A type session, bit of interaction between our well-trained guests who are very much subject matter experts, and we'll be running through different components of integrating sleep medicine into a dental practice. I'm Joel Simpson, one of the founders and directors of Good Sleep Co. I'll be moderating. I'll try and stay out of it as much as I possibly can. Okay, I think we're going to get started. So welcome, Hugh. Welcome, Alex. Welcome, Rohit.
Good evening, all.
Hi, all.
Okay, so we're going to start with practice integration and team setup. The first question that I have, we're going to start with Hugh out of the gate. So the first question we have is, how do you train your team to support the sleep workflow? Can you tell us a little bit about that?
Okay, well, it's been a bit of a process over the years to try and get a system that kind of fits into the practice, because we run it's a general practice that does all sorts of dentistry, and kind of sleep is just one part of it. And we developed the program probably about 10, maybe 15 years ago, that included pretty much all the team. And part of bringing them on board, we do like a full day in-house training of all staff, support staff, clinicians, hygienists, which takes them through what sleep disorder breathing is, okay, and the effects that it can have on patients' health, patient selection and testing, sleep disorder breathing indices such as AHI, RDI, and ODI, and snoring indices, the modalities of treatment, and the utilization of sleep and respiratory specialists, because it is a medical condition, and we should work hand in hand with the medicos in treating our patients. So it's pretty much an integrated full in-house training process that we take all the team through.
Fantastic. Alex?
Can I just say something there? I think it depends, like you said, what sort of practice you're actually kind of in. I guess I've been fortunate in my experience to work in quite a big practice where there was a lot of other clinicians, so like hygienists and OHTs, and I think they're actually really valuable in asking the right questions, provided they're trained correctly, to then have those conversations that might lead to some further investigations and testing, or a consult with the dentist. So it depends what sort of practice you're in, but I think getting the whole team on board is super critical.
Anything to add there, Rohit?
I think I agree with everything that Hugh and Alex are saying. I've come from a corporate background, working a corporate preferred provider practice, and that's where you kind of face the challenges, because it's not your team. Sometimes you might be short on staff in a very busy clinic. But it goes back to what Hugh was saying earlier about often the first point of contact will be that front of house, that front desk, and seeing things that flag up on the medical history, like snoring, for example, should almost start the question, should sow the seed for the patient to start talking about, can I do something about my snoring? Does your snore, you feel tired? Because, and then your team can actually get a lot of that information for you before they walk in the door. And it starts to progress that conversation, because the patient may just come in for their free check and clean or whatever, if it's a preferred provider setting or whatever. But you open that door to that before it being you being the pushy salesy dentist trying to sell them something they never wanted. If they see an opportunity, then that opens up that thing, and you can answer, provide solutions to problems they have, rather than try and push a product or something onto them or a test onto them. So I think what Hugh's saying is empower your team to open up that conversation is really key. And of course, they may not want to do anything that day, but then certainly at the 6-month review and so forth, they may be like, actually, wow, I've noticed I'm snoring a lot. My partner's really become aware of it. It's stimulated a conversation at home. I'm actually the place where I want to do something about it or investigate this at least. And that's really powerful. And then on the other side, when you are lucky enough to have those teams that maybe are your own in your own practice, you can empower them so that they are, starting those conversations. Exactly like Alex said, like we all know in ortho, for example, how useful it is, and it's well accepted that your therapist will probably sell more ortho or Invisalign than you'll ever do, because they'll see it and they'll have time to have that conversation and that trust and rapport there, and they'll send it your way. But it's exactly the same as sleep and things. They can pick it up and just start making them aware of the problems. They can start the conversation with you. And I think when you're seen as the person offering solutions to problems the patient perceives, that's powerful. And I think that should become almost the crux of it all.
That fantastic segue into the next question, and I'm going to direct this one to Alex. Who handles testing, follow-up, and education in your practice?
Yeah, so I work in 2 quite different practices. So at one of those practices, I do everything myself. It's not a bad way to learn. And in my other practice, I've got support staff to assist with that, particularly with the administrative side of things. Follow up emails, emailing questionnaires, organizing for the sleep study side of things, and also alerting me when reports are back or anything like that. So that's ideal, and even better, taking it a step further. If you work in a practice and you're fortunate enough, some practices have treatment coordinators. You could even consider having a dedicated sleep disorders coordinator or something similar. That would be ideal, but I realize it's probably not feasible for every practice and what their kind of setup is. But I think as a clinician you can do it, but you also have to think about your time and efficiency as well. And if you can train someone, going back to the previous question, to kind of take on board some of that administrative sort of role to free up your time for consulting and actually treating, I think that can work really well, from a business practice strategy point of view.
Yeah, Alex, I'm really with you on this. I think sleep is not one of those things that I think, if you're going to do it successfully and build a strong practice within a practice on sleep disorder breathing, you as a clinician shouldn't be running it. You should be guiding it, okay? And that's why, very much, we have a dedicated sleep disorder coordinator who handles, coordinates and monitors all the home sleep studies, makes the appointments, relaying HSD reports to both the patients and also the sleep specialists, sends videos to the patients, makes appointments and all those sorts of things, follow-up appointments, and post-NAS HSD reports and those sorts of things. So it really needs to be coordinated by a dedicated person who, in conjunction with both the clinicians and the rest of the team, kind of runs the program.
Anything to add there, Rohit?
I think again, so I'm in the situation where I've got a brand new practice, and I think I'm kind of doing everything at the moment because it's me and a DA. But I like Alex was saying earlier, it's a good way to start. I think because you have to know what to do, and you have to know the answer, and you have to understand the roadblocks along the way. So you only learn that by doing it yourself. But then as your sleep clinic grows and you start to get more patients, like both Alex and Hugh have explained, you kind of need more team members involved in the to streamline the process. Otherwise, it's literally all on you. It's very hard, and this is very much a team sport, like Hugh's been saying. So you can manage it when you're doing a few patients, a couple here and there. But as it grows and as you become more aware, and and you yourself as a practitioner will see the value of this, and you'll start seeing, and the more you do it, the more you'll see it everywhere, and you'll start seeing, oh my, your eyes will be opened to this really big issue, and you're going to have to incorporate the team, and so it becomes about empowering everyone with roles, from that first moment to testing to follow up. I do like to do the clinical bits and the follow up personally. I think it means more when there are certain touch points with the dentist and the dental professional. But I think there are things that anyone can do, like scanning or impressions or explaining how to use a sleep test. I think anyone can do that. But I feel like the clinical bits where going over a test is like almost like breaking bad news in counseling and medicine, where I think it's sometimes more powerful for a dentist to do it. I'll see how I feel in a few years' time. That may change, I don't know. But that's where I currently am at.
Right. This question is going to come back to you now, Rohit. So I think it opens a broader conversation at that clinical level when you are talking to patients and you do want to bring it up, whether it be bad news or not, starting that conversation. How do you actually start that conversation about sleep, maybe in general, and snoring, of course, so that patients understand and making that connection back to OSA?
So I think often the first point of call with a brand new patient is going to be things like snoring. And they'll often put that in the medical history form, and that should start or trigger a conversation about, tiredness, drowsiness at the wheel, maybe being tired in the middle of the day, not refreshed. And then that should then go into your, what's that called, the history, then goes into your examination. You will look for classic signs in the mouth and stigmata of parafunction that may suggest that something's going on. You may even look for signs of, if you're looking at full mouth rehabs and things, one of the things that I don't think we do well necessarily in Australia, but it's done very well, or becoming better done in North America and Europe, is full mouth rehabs, where they're looking for, have they got signs of OSA before? Because if we're going to start opening them up and moving into it restoratively into class 2, we might decompensate the patient, because they're compensating by overworn teeth and posturing forwards. But now we've opened them up again, suddenly that compensation's gone. So at the end, is the correct thing to give them a splint, or is the correct thing actually to give them a mandibular advancement device to protect the airway, or do they need something else, MAS plus CPAP or whatever? So I think whenever we're looking restoratively, or whether we're looking at a patient coming for the first time, there are lots of signs of the history and examination that should get us. But we should also be looking at signs of in patients who've got multiple comorbidities, in terms of their hypertension or whatever's going on, cardiovascular disease, all these things. And it should trigger these conversations to start, and even just risk stratifying them through like the questionnaires many of which everyone already know about, many that we will do in-house already. But we should be starting to think about how do we start risk stratifying these patients. Again, they may not jump on board straight away, but I think increasing their awareness and allowing them then to come to us to try and help them push them along that pathway is certainly key.
Fantastic. Alex, did you want to add to that?
Yeah, no, that was a great answer right here, and I completely agree, and I can't emphasize enough the importance of the medical history and looking at comorbidities in terms of starting a conversation. And I guess going back to one of the previous questions about getting your whole team on board, training your staff. In one of my practices in the waiting room, we've literally got like a PowerPoint that's on display that talks about like asthma, hypertension, and did you know that these conditions are related to a sleep-related breathing disorder? So just simple things like that while people are sitting there waiting and looking up at the screen might sort of get them sort of thinking in that mindset. And I think that just becomes a lot easier than when you've got that sort of material on display for everyone to see front and center. It just becomes a lot easier to start those conversations, definitely.
It kind of reminds me. Oh, sorry. I was going to say, like, actually, it kind of reminds me of, like, when you see that yellow car, go, oh, I've never seen that car before, and then suddenly you see like 5 of them. That's why I kind of feel that's really good. Like, I've always thought about that in the waiting area. Like, do we need to run those things on the screen rather than just running like the miserable news and all the depressing stuff?
Yeah.
Just
I think it's helpful. Yeah.
Just extending on Rohit's comment there about coming into treatment planning and overall treatment planning. And I think, okay, yes, you've got your new patients with your medical history and those sorts of things, with some questions on snoring and sleep apnea and fatigue and those sorts of things, which opens the conversation. But I think also, with some practices, I know for myself, I've been treating patients now for over 41 years, and they reach a certain age where, you start to see deterioration in their dentition. You're seeing cracked teeth. You're seeing, they're constantly breaking teeth. And all of a sudden you're seeing bilateral scalloping in the tongue, melonpathy, and you look at them, you say, okay, melonpathy type 3. It brings in the conversation as, why are you starting to break all these teeth? Okay. And then, do you snore? Okay. So it's not just the new patients, it's the old patients in your book as well. Because medically and physiologically, people change as they get older. They put on weight and whatever it might be. They have other comorbidities that kind of kick in, and snoring and sleep apnea can become a major part of their life. So often you've got patients in your book there already that the conversation starts just around examination and treatment planning.
Do you know what, Hugh? Funny enough, the patient I saw just before this is a patient I've been looking after for the good part of at least 8 years, and we're just doing a load of quadrant dentistry, redoing some old work, and they've got a bit of caries around some old work and stuff. And funny enough, he's been falling asleep in all the appointments and snoring away, chugging away. And the one thing I said to him, funny enough today, I was like, at the end of this, when we finished all your treatment, you need a couple of implants doing. I said, we're going to do a sleep test.
Yeah.
I was like, I'm convinced you have sleep apnea, and I was explaining why I thought this and what's going on. He said, like, yeah, I'm tired during the day, etc. All that. I was like, I'm just convinced that you're going to need a mandibular advancement device at the end of all of this, and that will protect your implants and your existing work and everything. But it's exactly as you're saying, Hugh. It's so true. Sometimes we can just, like, we've done it and then we don't ever come back. Sometimes revisit our existing caseload, but it's so true.
And also, again, those who've got dental hygienists or therapists and so forth in their practice, patients will often tell those clinicians before they'll tell the dentist, okay, I've got a problem with snoring or whatever it might be. It just may come up in conversation even, So that's why it's so important, I feel, to have the whole team on board in these sorts of things.
Fantastic. The next question was probably a little bit more clear cut in, potentially more a technical question. How do you screen patients for sleep disordered breathing? So, in the sense of, are you using screening forms or tools, to help you screen for sleep disordered breathing? Hugh, do you want to take that one for us?
Yeah, that's a pretty kind of like a step-by-step process, or how we tend to work it, in that it starts with the medical history and assessments of comorbidities, okay, of, weight, blood pressure, okay, and BMI measurements. Obviously if someone's got a, BMI of over 30 and high blood pressure and diabetes or whatever it might be, these sorts of things, you've got to start asking, okay, they're a prime candidate, okay, for sleep apnea. and should be assessed. Pre-home sleep study questionnaires consisting of sleep quality questions, the standard ESS, Thornton snoring scale, and those sorts of things. Sleep study history, have there been past treatment? So there's a whole questionnaire that we give the patients when we're leading into doing actual home sleep study, which that they fill in their medical history, past dental history, what anti-snoring measures that they're doing now. You know, some of them are using strips and doing all sorts of things, positional devices, wearing things that vibrate around their neck and all these sorts of things. And it's snoring is such a more of a factor than sleep apnea when it comes to patients recognizing that they have a problem or their partners recognizing that they have a problem. Social history, you know, alcohol consumption, use of sedatives, caffeine consumption, you know, weight gain, loss, all these sorts of things need to be assessed as well. So it's kind of like gradual screening process, okay, before we get to the actual sleep study itself. Dental history, I've touched on that, you know, history of grinding, cracking teeth, you know, waking up with a dry mouth, those sorts of things. And clinical history, you know, Mallampati score, linear alba, scalding of the tongue, tooth attrition, cracking, TMD symptoms. And what's something else I also find really helpful in that screening process is a cone beam, whereby you can do a volumetric analysis of the airway and bring it up in front of the patient and say, look, this cone beam was taken with you in an upright position when you're awake, okay, and you have, you know, a restriction of the airway of 82 square millimeters, okay, anything below 120 is physiologically not good, okay, and can lead you to a higher risk, especially when you're lying on your back, it's in sleep, and you can stage 4, stage REM sleep, and everything's relaxed. So those sorts of things, measures, I think is what we use pretty much to screen from the top down.
Brilliant. You just mentioned about 100 risk factors for OSA there, so really impressed you were able to just rattle that off the top of your head. Well done. Rohit or Alex, is that? I don't think there's anything else to add there, but if you have anything,
yeah. Look,
come on, Alex. Come on, Rohit. I'm sure you got some more.
No, I think that was great, and like you're right, there are so many different, let's say, phenotypical presentations that might suggest someone has a sleep-related breathing disorder. A really useful guide that I still use today. I know this discussion is more centered around adults, but there's a pediatric version as well. It's called the FAIREST, which is the Functional Airway Screening Evaluation Tool. It's from the Breathe Institute, and it's a visual. So even if you're not a clinician, a member of the public, a patient, you can instantly kind of relate to all these pictures, and it's very simple, yes or no. Some of the other stuff might be a bit more technical, but I bring it up in front of the patient and I risk stratify them, what Rohit was saying before, in front of them. So if they're ticking quite a few boxes, they're already going up that, severe end of the spectrum. And then that invites a conversation about, well, maybe we should investigate this further. Maybe we need to look at a sleep study, CBCT, etc. So I think the FAIREST screening tool is actually a really good visual for that anyone can really use.
The other thing, sorry, just one other point that I really like about those kind of screening tools is that they do lend a little bit more towards OAT being a good therapy option for those patients, comparatively to PAP. We can, if we can get, that critical pressure, of the airway collapse, we can understand a little bit more about whether OAT is going to be useful for that patient too. Sorry, Rohit.
No, that's fine. It's great. I'm gonna say I think it's funny because I used to sit on an advisory board with Hugh for a few years, and I remember the sleep thing came up, and I was blown away by Hugh's system, because he's been doing this for a long, long time. He's got this very well established system into practice, and which can be daunting, I think, for many new people coming into it. But it was fantastic to hear from and actually be able to speak to him about it. And we had a couple of conversations about this after our meetings, and it was great to learn from him how he makes it work. And I was messaging him and actually plugging his brain about it a few times as well, and his team, which was great. So it was a very useful thing for me to learn from. I agree also with what Alex is saying, though. These these screening tools are very useful. Many people are probably already in practice are using like the stop bang tool. You know, if someone comes in with bruxing or parafunction as a means of, you know, trying to work out their kind of low, moderate, high risk kind of scenario. And these tools exist. They're good ways, and we talk about the Epstein score as well. And all these tools serve a purpose for risk stratifying, and also just kind of guiding our patients into where we should be going, what we should be thinking about, and effectively red flagging at-risk patients and trying to offer them solutions for their health. So I think, but it also makes it very easy to remember, very easy to work with. When you've done them a couple of times, they're quite easy to get on board. I think sometimes in dentistry, we just get so into just doing the checkup and clean and things. And I know that's what the patient's coming in for. They want a quick clean, basically, not even coming for the checkup. They just want a clean to get out of the door. But actually, you know, it's a bit like going for a car service. You know, if you took your car for a service and all they did was just wash the outside of your car, but they didn't tell you that the tire tread was going too thin. They didn't tell you that your gearbox was going to go out and give way, or whatever, or your oil needed changing and things, and didn't do it. You'd be pretty disappointed if you end up in a car crash down the road within a few months. And that's what we're doing when we don't actually do a comprehensive exam. We're actually kind of cheating our patients out of what they really came for, not the quick clean, but a state of health. You know, we've heard about well man checks, well woman checks in medicine, with the general medical practitioner. You know, getting your yearly kind of screening and things. But that's what we're doing in dentistry with the comprehensive exam and the periodic exams. We're checking what the state of their health, and then we're periodically reviewing. And every 2 or 3 years, we go back to the comprehensive again, where we really like do an overall review. Because exactly as Hugh's saying, as we age, things change. As we wear and tear, things change. We should be reestablishing where they're at that point in time.
Great. I think we're going to go back to you now, Alex. How do you decide between using a home sleep test, or you know, your preferred sleep testing option, or just referring out to, let's say, a sleep physician, or you know, somewhere else where you think they need to go? How do you make that call?
Yeah, look, there's probably a bit to unpack in that question, but
Yeah.
the short answer is it depends. I think first and foremost, if you are going to kind of get into this field in terms of sleep, you really need to kind of be aware of what other sleep disorders are out there. So we're talking mainly about sleep-related breathing disorders tonight, which makes a lot of sense for, you know, dental practitioners. We've got intimate knowledge of the anatomy and physiology of the upper airway, but we do need to be aware that there are other sleep disorders out there: parasomnias, circadian rhythm disorders, central disorders of hypersomnolence, etc. Because often those other non-respiratory sleep disorders can coexist with a sleep-related breathing disorder. And if you simply are only sort of looking for the sleep disorder breathing or OSA, you might be you know, doing your patient a disservice. You might be missing something when they could have got, you know, more appropriate investigation or care through, you know, a medical colleague or practitioner. So that would be the first point I would make there. It depends on what you suspect as a clinician, and that goes back to the history taking. So taking a good history, looking at the medical history, the comorbidities. You know, I had a patient, I think it was last year. She had a history of trauma to her head, and she was, you know, complaining of symptoms, you know, that probably would be consistent with a sleep-related breathing disorder. But, you know, for her, maybe there was some central sleep apnea there. So, you know, that was one that I sent her back to a GP and then on to a sleep physician. But, you know, there are other situations where it may be appropriate to, you know, go down that pathway. But if, you know, everything is, let's say, looking low risk, there's, you know, you're not concerned, there's no comorbidities, you're not worried about any other sleep disorders based on your history assessment, etc. Then it comes back to those 3 questionnaires. So the Epworth sleepiness scale, the stop bang, and the OSA 50. And I kind of use those as a guide to determine what level of sleep study that we're looking at. Typically for me, and I realize that some of the other clinicians might differ in this, but for me, anyone who meets the Medicare criteria based on those 3 questionnaires is getting a level 2 home sleep test. There's a couple of organizations around that that can do that. But if someone's meeting those Medicare criteria, which for ESS it's 8 or above, for stop bang it's 3 or above, OSA 55 or above, they're already at high pre-test risk of moderate to severe obstructive sleep apnea. So that's already a huge red flag. If someone doesn't meet the Medicare criteria, sometimes can pay out of pocket for those, let's say, level 2 sleep tests at home. But typically, again, if it's low risk and I'm not worried about anything else, then maybe that patient is a good candidate for a level 3 or 4 sleep study, depending on what we're looking for. And so, typical example is the use of a watch that a patient can take home. Good sleep test is a perfect example there. And the good thing about that particular test is patients actually get to keep that device and they can monitor their own sleep as well, in addition to the clinician setting up a test and getting a sleep physician report. So yeah, a bit of a long answer there, but I think it really depends what you're looking for and what the risk factors are for that person sitting in front of you.
Brilliant. Hugh, Rohit, anything else to add there?
For me, I would say kind of down, I think like what Alex is doing is extremely thorough, which is great. And it's certainly what we should be looking to attain and achieve. I go down the line of I think like if you've got a patient who has got signs or concerns or red flags, and you've risk stratified them, and you think that they're a risk of sleep apnea. One of the biggest problems I think in Australia has always been that we had this issue where you had to send them to their GP, and then the GP had to refer them out, and then to a sleep physician or whoever, and to get down the Medicare pathways, and you almost set so many hurdles up that they were kind of doomed to fall in a way. And so sometimes, if a patient's not willing to do it, or you're kind of worried that they're just going to just disappear into nothingness, it's pretty cheap and easy to give them a home test to do. Again, it not necessarily to act on it per se, but maybe just to make them aware, hey, there is a problem, all right, and push them further down that line, and maybe going to actually have a proper, overnight test would be a good idea. And I think it can be used to lower the barrier, to lower the threshold, to say, like, I think it's in your best interest. And 100%, like I say, when you've got those high-risk patients, especially the ones with the comorbidities, especially when you're concerned it might be a central problem and you're not quite sure, like, it's just a way of reducing the barrier, because sometimes they don't see the value, and sometimes they're sitting there going, oh, it's a massive rigmarole, I'll get around to it, and they never get around to it. 6 months has gone, the next checkup, but did you do it? No. Then another 6 months gone, did you do it? No. I'll get around to it. It's just such a schlep. I get that. We're all like that a little bit inside. I totally understand. I think like we're seeing more and more ADHD types out there and stuff as well. I think we can all relate to that kind of putting off, especially with our male patients and stuff as well. And so sometimes it can be used as a tool, not necessarily to, as I said, to get them into a mandibular advancement device, just to show them and make them aware there's a bigger problem. Go, hey, look, so you've definitely got a problem here, but my gut's telling me right now, this isn't just a simple thing, which it could be something else going on in the background. So I just want to get you a better screen done. And it might be a way of pushing them along. So I do think having those take-home tests are really, really useful for many levels. But then obviously when you've got a low to moderate risk, which is like Alex is saying, that's when you go like, they're really good to go ahead with those, and they're very convenient. But exactly like Alex saying, I think Alex is saying it in a much nicer way than what I've said.
No, I actually, Rohit, you make a really good point. I've had so many patients, usually happen to be older and male, who tell me, they're ticking all the boxes, and they're probably, definitely have severe obstructive sleep apnea or whatever. And they tell me, I don't want all the wires over me. I just want to, make this simple. I'm time poor. What can you do for me? And I say, yeah, look, take a watch home, and let's see what comes out of it. At best, we can use it, as maybe just a screening tool to kind of, like you said, highlight that maybe there is something more serious going on here. So yeah, I think it really does depend on the situation, but yeah, that's a very good point.
I think both Alex and Rohit have made two very, in summary, very important points. Okay, Alex, you've really stressed medical history and proper screening, okay, to determine comorbidities and where patients are lying at. And Rohit, you touched on, you know, getting patients off this referral merry-go-round, that, you know, it's all too hard to go around from the dentist to the GP to the sleep specialist to the sleep study lab, back to the specialist, back to maybe the dentist again for a MAS or whatever it might be, because they just end up not having been treated. And I'd much prefer to see patients treated or get into some form of assessment, which may then lead to a referral to a sleep specialist, or it may go straight to a MAS or something like that. And what we tend to do is that we'll either use either a type 1 or a type 2, type 3 or 4 sleep study, either a watch or a Medibite Junior, based on what comorbidities that patient presents with. And then based on what readings or indices we get from AHI, ODI, whatever it might be, might then lead to a referral to a sleep specialist for ongoing assessment and treatment, or if it's managed mild snoring, can be easily treated with a MAS. You know, we'll talk about CPAP, we'll talk about other things, but we'll also introduce a MAS appliance.
That was a great addition, and also a good segue into another question, Hugh, which is, how do you explain those treatment options to patients, particularly when you have that report in front of you? How do you go from you know, oral appliance and talking about PAP and potentially lifestyle changes or lifestyle modification as a treatment option? How do you approach that
with the actual the results of the
Yeah.
HS report?
Yeah.
Okay, well, we'll sit in the consult room and do, depending on what test we've done, you know, if it's say a Medibite Junior, a type 3, I'll actually bring up the graphs and show the snoring, so show the sleep apnea, so show the oxygen desaturation, body position, and those sorts of things. Okay, which then lead into a discussion of the indices, AHI, and so forth, which will then give us a reading as to what level of sleep apnea they may or may not have. Is it just a snoring problem? Is it mild, moderate, or severe sleep apnea? And likewise with the Good Sleep device, okay, it'll give us similar sort of readings, but maybe not the snore flow and those sort of things, but at least it'll give us a level as to the next treatment pathway for, you know, for the actual patient. And then we'll discuss, okay, what treatment options are there? And we'll always, you know, we'll discuss CPAP is an option, or may not be an option, or you need a referral to a sleep specialist to take this further, or you know, we could look at a mandibular advancement splint. You know, the body positional devices and those sorts of things, we'll discuss weight loss, lifestyle factors, and those sorts of things as well.
Brilliant. Alex?
I was just going to say that, yeah, I get some people come in and they know that, you know, they need a sleep study or a sleep test, and so that's already, you know, an easy conversation. But they've also told me from the outset, I don't want a CPAP. I'm just here to get a dental device. And so it's quite an easy conversation to have when you're going through the sleep study, provided there's nothing, you know, let's say untoward there that might need some medical follow-up care or something like that, from either the GP, sleep physician, ENT. But, you know, there is a handful of patients that will tell me that I'm literally just here to get the dental sleep device. So it's sometimes a really easy conversation, actually.
Can I just add one point to that, which I think is really important for those that are listening to understand, is that both the American Academy of Sleep Medicine and the American Academy of Dental Sleep Medicine have advised that it really is patient choice, you know, even for patients that are in that severe category, because if they are resistant to or reluctant to do PAP, then, you know, we're not getting any result. It's like, you know, what's anything times 0 is 0. So that they have changed those guidelines in recent years, and we're certainly in that period of time now where oral appliance therapy is certainly considered a valid option for almost all patients with OSA.
Not only that, Joel, but you've also got the group of patients who are CPAP intolerant, and they've tried CPAP, they've tried different masks, different devices and so forth, and, they either opt out of it altogether, and then they've then got a continuing medical and health problem, unless they're introduced to a MAS device. And, we see a lot of patients who, yes, are on CPAP, but don't want to wear their CPAP sitting in an airplane traveling overseas or going away, and those sorts of things as well.
Yeah, that's a brilliant answer. Okay, so I want to ask Alex a question. How do you frame the value of treatment as a service, not a product?
Yeah, so when it comes to dentistry, there's lots of different things that we can do. We can change someone's smile, and that can have positive impacts on quite a few things for them. But for me, working in the sleep field and orofacial pain field, I find that there's a lot of reward there as the managing or treating clinician. And at the end of the day, it's really, for me, the conversation is centered around that individual's health and their health span, and their vitality, and the long-term side of things. So for me, that's a service, and whatever products or appliances or whatever we end up using, that's they're just facilitating that goal of addressing those concerns of that patient. So for some people, and probably a lot of my patients, snoring is their main concern, and they're not tired, or they don't have any other issues. And so that can have a profound impact if you're able to assist in that way, using your knowledge and skills to help that patient. I think it's quite easily seen as a service that has far-reaching effects, not only on their quality of life, but also potentially their long-term health as well. Like, we all want to feel, waking up feeling refreshed, vital, more energy throughout the day. We don't want to disturb our bed partner. So, these are really, I think, important things that, we have the privilege of being involved in as dental practitioners. So, for me, it's I've always seen it as a service, and it's never been about the product.
Brilliant answer. Rohit, anything else to add to that?
I think exactly like Alex is saying, you're kind of reframing the whole thing around health. It's not about how they go about it with this, whether it's CPAP or whether it's a mandibular advancement device. I think often in the report, and this is a great thing we got to remember. It's a blessing and a curse, the fact we've got to go through other clinicians and things. But yes, it's a rigmarole, but the truth is, how great is it that we can lean on our sleep physician colleagues who will actually also help us guide that conversation, because we get a report and it says, would they benefit from one or the other? Now, patients can do trials of PAP if they want to give that a go, if that's appropriate, or they can do even a simple, like a cheap boil bite kind of scenario, just give it a trial, take the home test, see if it improves things, and go, oh, actually, no, I think I will wear it, before they commit maybe to the more expensive one. I think that's a really great option for them. And exactly like you're saying, many people, they'll have the CPAP device, and then they'll be like, yeah, but it sucks for traveling. You have to get get on the plane and things, and explain it and take it through. It's a nightmare and rigmarole. Also, having like just a small little thing that you could put in just for convenience if you're away for the weekend or whatever. It has a role, and people even with severe sleep apnea can benefit from dual therapy. So, I think it shouldn't be about what they use. I think it should be about getting the diagnosis at the end of the day. And that will kind of guide everything, because more important, well, not more important, but at the end of it, it comes down to the patient's overall global health. And again, there's so many different comorbidities we could be improving if this is a root cause, if this is part of that whole thing. So we should be focused on that. But also, like, as general dentists, it protects our general dentistry. It protects, like, your ortho could rapidly relapse because of, we haven't correctly diagnosed the underlying cause of their orthodontic problems, whether it's airway and so forth. Our restorative dentistry could rapidly fail our full mouth rehabs if we haven't correctly diagnosed. So we're actually trying to protect what's in their mouth. We're trying to stabilize them, and we're trying to look after their global health. That's our primary goal. How they do that is very much secondary.
I think.
Yeah.
Sorry, I think the discussion we need to be having with our patients is that it's not around a device, whether it be a mandibular advancement splint or whatever, but it's the proper assessment and treatment of a medical physiological condition, sleep disordered breathing, whether it be snoring, flow limitation, or whether it be obstructive sleep apnea, which has long-term deleterious effects on a person's health, especially if it continues over a long period of time. And to do so, it requires proper testing, proper screening, proper assessment, treatment, whatever that may be, and then follow-up treatment assessment with HSTs to test the actual efficacy of whatever treatment modality is being performed. And especially over a long period of time, as people age and their physiology changes, they gain weight, whatever it might be. So it's certainly not a device or a product. Okay, it is a service that is developed and is performed over a long period of time for patients for a medical condition.
Fantastic. Rohit, what do you say to patients who are skeptical?
Patients are always skeptical. They always think you're trying to sell them something, unfortunately.
What do you say to every patient?
Do you know what? Whenever I talk about things like Invisalign, which is often a lot of what I do, my spiel with those education things always tends to be around, I want the patient to ask me. I think the first step is about making patients dentally aware. You can't provide treatment for a patient for whatever it is if they're not aware there's a problem. So your first goal is to make them aware that there's a problem and encourage them to ask you about the solutions to the problem. Because it's a very, very different conversation to you saying, you need this. And then it's like, oh, you're trying to sell me something I don't want. Or I didn't see the benefits of that or the point of that. That's when you get disgruntled, unhappy patients because they don't understand. The key is always to get the patient to understand what the problem is. You can't treat someone who's unaware, who's dentally unaware. You can't get adequate consent from someone who's unaware that there's a problem. So what you're trying to do is raise their dental IQ. And that comes through education and spending time. As I said, you may not be visit one, but over time, if you get them to see the value, sometimes you sow the seed and they go, like, we've all had that patient. You say, you see signs of parafunction. And they go, oh, I don't grind my teeth. Because they think it's going to be like a Tom and Jerry cartoon where something like, and everyone will be waking up. And that's not how it works. We know that people just clench. We know there's daytime clenching. There's lots of factors. Parafunction is not necessarily that classic nighttime grind teeth like crazy. It's abnormal function. It can come in many shapes and forms. And so you first have to make them aware there's a problem. And then sometimes you make them aware, you don't argue or fight with them. They go away and then literally they'll call you up the next day or 2 weeks later. They go, oh my God, I'm grinding my teeth, because you've told them about all those things. And like me and Alex were just saying, you made them aware of that yellow car and they see like 5 of them go by. Suddenly like, oh my God, my jaw aches in the morning. I didn't realize this. I've started knowing, or over 6 months, the next check, like, yeah, I started wearing down my teeth. Or they're moving. Because, you've got excessive force, what happens? Something has to break that force. The tooth moves, the tooth breaks, the tooth wears down. Those are the only things that can happen. So something has to dissipate that force. So they become aware of it. So once they're dentally aware, they start seeing what's going on. They go, oh, wow. Now you're like, oh, look, we spoke about, I think we should do something about that. They've got to see the value. So we don't try and sell them anything. We just educate them. That's our goal, I think, as clinicians, is to educate them. And inevitably, they will then start asking us for, hey, I see value in this. What's the solution? What can we do? what are the next steps to progressing this journey? And I think that's where we take them and guide them down that journey till they come to an endpoint, whatever that may be.
Brilliant. Anything to add, Hugh, Alex, there?
Yeah, I just think, the skeptical patient, skepticism can be avoided by education, and hit the nail on the head. And that really, starts as the patient walks in. That education starts even before the patient walks in the door with our social media exposure, marketing, and those sorts of things. And the big majority of the population aren't aware that dentists can treat snoring and sleep apnea. Okay, so the more we educate the general population that these treatments are available, you have the patients walking in the door asking about a solution, rather than you introducing the problem and saying, I have a solution.
Yeah.
Great.
And I was going to say, I've been, I guess, in the situation a couple of times where, and I'd be keen to get the other panelists' thoughts on this, where you might start a conversation about sleep, or some of these symptoms that or signs that you might pick up from your patient, and they start to get a little bit skeptical. Why is my dentist asking me about sleep? And I think there is just a general lack of awareness, although I'd still really say it's improving, but slowly. And I guess the other thing which I'd be keen to hear the others' thoughts on is the level of training of the general practitioner in sleep. And I've got several colleagues, friends of mine, that have gone through medical school. Some of them are specialists in their own right now, and I asked them, how much training did you get on sleep? And I think all of them said about, we had a lecture on it in third year or something like that. And so I think even from the medical community side of things, that maybe the awareness isn't there either. But hopefully in the years to come, that's going to change.
Well, Alex, I graduated medicine maybe 20 years ago, and I don't remember doing sleep at all. But it was 20 years ago, but I think I learned more when I did my respiratory medicine jobs as a graduate than I ever learned in med school. It wasn't a thing. And even with dentition or oral biology, that wasn't really a thing for us in med school, at all. So then you feel like an abs. If someone came in with anything white on the tongue or the mouth, it was just Canada. My statin, that was it. Everyone's got it genetically. And then you go through dental school, you're like, oh my God, what was I doing? What were we doing? We should be allowed to look at the mouth.
Brilliant. All right. Moving on. How did you develop your titration protocol, and how can new dentists create theirs, Hugh?
Okay. Titration. So once for a MAS device, once it's given to the patient's sent away for a week, and they're brought back and then assessed, and the normal questions then arise. Okay, how are you feeling? Is it how many reports are you getting from your partner, your bed partner, with regards to snoring? How are you feeling in the morning? Are you waking more refreshed during the day? How are you feeling? And these sorts of things. And if they kind of walk and say, look, this is just amazing, I wish I had done it 20 years ago. My wife and I now, or my partner and I, are now sleeping in the same bed again, rather than separate bedrooms. All this sort of stuff. Okay, I think we've kind of nailed it with regards to the position of the actual device. And I'll say, well, okay, that all sounds really good subjectively, but let's get a numerical approach to it as well. So we will send them home and to do another sleep test with the actual MAS device in, which we'll then get back, and we'll go through that report with them. And obviously, if we're seeing a halving of indices and AHI, RDI, and all those sorts of good things, oxygen saturation's improving, we've pretty much done what we want to achieve, and then it's a matter of just periodic recalls. So all patients when they come for their hygiene appointments, they're reminded to bring their MAS appliance to assess and to assess the overall efficacy of the actual MAS appliance and their treatment. If they come back in that week and they say, yeah, there's been some improvement, but my partner's still saying there's some snoring going on. Yeah, some mornings I feel really great. Some mornings, no, not that fantastic. I say, okay, let's titrate you forward another 1, maybe 2 millimeters, depending on how much movement we've got, and also depending on what their overall comfort from a TMJ, TMD morning comfort might not be. So we'll send them away, okay, having titrated them forward. And so we kind of do that process. We'll nail it the second time. Rarely would we need a third. And again, we followed up with another sleep study to ensure that the indices have come down and that we're achieving what we want to achieve. So that's pretty much our titration protocol, for whatever you want to call it. It's based on subjective factors and also numerical backup.
Yeah.
That's fantastic.
And sorry, might I just add, since it's a good sleep webinar, okay, the beauty about the good sleep test, okay, is that they have their watch, the device, okay, so they can monitor themselves at any time, okay, and they may have a change in lifestyle or whatever it might be, or their partner might say, oh, some more snoring going on. It's really quite easy for them to log back in and do another sleep test.
Yeah.
Love that. Thanks for the plug, mate.
I think we just should mind we look at the dental schedule, and one thing it does say is if we're providing it, number one, they've got to have a verified, it's like a sleep study from a sleep physician that says that they would benefit from it. Number one, which is great because then we get the guidance then from a peer sleep physician who's doing the helping us make sure that there is an adequate problem with treating, but also it says that we should be following them up is one of the stipulations. And so I think we've got to remember then that's where, as you mentioned, having that device makes it really easy to follow them up. I think that's key, and that's where sometimes if you've sent them away and you haven't really, and then sometimes patients can disappear and not do it. But again, if you lower the bar by giving them a device where they can do it, and you can be able to see in the background as well what's going on, that there is an objective finding of of benefits, then you're like, cool, Zang, keep going, like you're fine, you're good in a good place. But it's great because it's great for the general dentist, because what a good way to build loyalty into your clinics. Why not use this as a way to, when they come in for their checkup at 6 months, just use it as a touch base point, or suddenly they've got an ongoing subscription going on. Some people love like trackers. Some people just love tracking everything. You're gonna find these patients who love it, and so they'll be in the build up to their checkup. They'll be tracking like, hey, what do you think of this, whatever, blah blah blah. And it's a great way to build rapport with your patients, build lifelong patients who want to come back, because they gain that overall kind of that whole holistic kind of care for them, for their health and everything, their dentition. Great way to build loyal patients around your clinic.
Yeah, I agree with what Hugh and Rohit said. I think start with the subjective, and then you want to see some objective data as well. And it's also, for me, if we are sending back to the original referrer, say if it's a sleep physician, it's nice to have that objective data to go on, to show that, well, look, we've optimized everything as best we can. Now it's over to you for the the follow-up medical management side of things. And like the other two panelists were saying, the good sleep test is great because patients can purchase the device, keep it, and use it to monitor their own sleep if they choose to. So it's a great tool in that sense as well.
There's a great answer to that question, all. I had something off the back of that, which I thought was good. And Hugh, you answered this kind of already, but I'm going to direct this to Alex. What subjective and objective markers do you use to guide titration?
Yeah, so for me, once we've kind of established that we're doing a mandibular advancement splint, I mean, I kind of already have an idea of this anyway, but I'm quite direct. I ask, the patient, what are your goals for, this treatment? What do you want to achieve? And I've heard some really random things, like I want this to prevent me from getting a heart attack, or I want this to cure my insomnia, you name it. So, but it's a good question, because then you kind of you're setting the expectation, or at least you've got an idea of what that patient expects from this treatment. Now, thankfully, most patients' answers aren't like that. And, a lot of it is, look, I just want to, reduce my snoring, or I want to wake up feeling a bit more refreshed. I want to wake up less throughout the night, whatever it might be. They're the sort of more common ones, less tired throughout the day. So I ask that question because then that's my kind of metric for, how things are going subjectively, before thinking about doing any further, I guess, objective sort of testing. And the really difficult patients, and thankfully there's not too many of these, but occasionally you do get someone who says, I don't have any symptoms, but yet they've got, moderate, severe obstructive sleep apnea. I kind of take that with a grain of salt. And some of these patients, I mean, truthfully, they may not know that they've been having, this problem for so many years of their life that it's just become normal for them. And that might explain why, they don't have this perception of having any symptoms. And it may be that until they have some treatment like a mass, they actually, find, well, actually, yeah, I am waking up feeling more refreshed, or I am waking up less throughout the night, or I am less tired throughout the day. So yeah, I think it kind of depends on the individual and, what their goals are, and what they've come in with. But yeah, just reiterating what we said before, start with the subjective and then follow up with the objective testing, to get that, ideal treatment position for the mandible, but ideally still within a comfortable range. You don't want to overexert someone's masticatory system capacity. You can, do that in a controlled manner and do it slowly, if you have concerns, but you don't want to take someone from 50% to 80% in the course of a few nights. I like to take things a little bit slower.
Hugh, Rohit, more to add there?
No, I think like Alex has like more than adequately covered it. I think it's one of those ones that's just it's a bit of a dark art, really, isn't it? I think one thing that I probably will take from Alex is that I think what I don't do actually is I don't actually do what Alex, I think is excellent, which is ask them what they want to get out of it. I think definitely understanding objectives and goals, and whether you're doing aesthetic work or everything, I think it should always be patients presenting complaint that guides, what do you want to get out of this? And I must say, actually, I haven't done that when it comes to my sleep patients, which is something I'm definitely I've learned today, and I will definitely take on board going forward, because that sets you with real objectives of, have you got subjective benefit from this, and patients should have subjective benefit from their treatment. Certainly, what I do is, when it comes to getting that device, if that's the path they've gone down, it's that initial phase of, because you have to send them home with some objectives, some guidance on when to how to titrate it, because they're going to be doing this free at home. And I think the Hush Pro product with the Good Sleep Company makes that really easy, because you have 2 upper ones, 3 lower ones, and then you titrate. So you start with upper one and lower one together, and I just get going gradually. And you've got the instructions in the box as well, which is great, which has got patient notes in it as well as doctor notes and stuff, which is fantastic. But I just show the patient what I want them to do. Just start at the bottom end. You don't have to ramp up to the end. Just get to the point where you're comfortable and you've got subjective benefit, and then and then retest to get them to see objectively if this is making a difference to you. And if it is, park it there and stop. You may need to go forward later on, but you have to push yourself right to the max. I think some patients feel they've got to get to the end point, like right out there, but you don't have to do that. Just get to that comfortable point. But that's the subjective element. But you do need to objectively, and that's part. We've got to remember that is a requirement. Objectively confirming that they're reaching that outcome. So I think, but it's good to document that and keep them subjective benefits. Yes, they subjectively feel better. Objectively, where are they? And then also at the bottom, have they attained the goal that, as Alex does, have they got there? I think that's really important. And that's really important to keep meticulously noted in your records as you go through it. But I think the objective settings are pretty much like, you're looking at that kind of the quality of the sleep and the AHIs, and that's what you're looking at. But you should be looking to hit idealization. Remember, it's not necessarily going to be a perfect score. Sometimes you just try to show improvement. And I think sometimes you get lost, and it's the same when you do like adult orthodontics and things or whatever. Sometimes you get lost in these ivory tower idealisms, which may not be possible, like because their biology doesn't allow for it. So I think you've got to have as a clinician, have realistic objectives as well as to what is beneficial.
I really like that. I think the other thing, which you both, or you're all kind of alluding to as well, with the follow up and titration and the management of these patients, is that if you can ask Alex a brilliant question like, what are you trying to get out of this? For me, that's a huge one, because why is the patient actually coming in? Can we reinforce? And then will that, propagate them to go and talk to other people and tell, maybe their doctor, maybe their friends, maybe their family, that oral appliance therapy is really great for them. And the other thing is that all of those things you mentioned, or those two things you mentioned, heart attack and insomnia, the sleep reports that we provide, most companies will provide you, if you're doing ongoing monitoring, will actually be able to prove that with objective data. Insomnia, you get wakefulness after sleep onset in most of our reports, but also others. And you're also getting, sleep architecture changes and things like that too. So you can show the patient objectively that this is helping. And then I think as well, cardiovascular wise, with risk now, we're starting to understand a little bit more about the influence of, or the importance of hypoxic burden, and how much, oxygen desaturation is really impacting that patient's cardiovascular health. So there's some really easy wins there. It's almost like we could do a whole session on the things that patients want to achieve and what you as a practitioner want to achieve, and what are the ways in which you can show them and reinforce that with them. So I appreciate that. That's a really, again, good segue into just the next question there for Rohit, which was, what does that long-term patient monitoring and device reassessment look like? What are you doing 6, 12, 18 months down the track for the patient? What are you doing with the patient and their actual device? Maybe even to the extent of, when you're looking at renewal, when you're looking at making a new appliance for that patient.
It's funny. I think it's something I admire Americans for, like the North Americans. They're really good when it comes to this kind of stuff. Where it comes to dentures or retainers or whatever, you've all had it, right? Everyone in this meeting has had it, where a patient comes in and goes, well, will my retainers last for life? Will that restoration last for life? And I kind of bring it back to, because I paid a lot of money for it. I go, well, those nice pair of like Nike sneakers, will they last for life? And I'm like, no, they're going to wear and tear. But yeah, this isn't going to last for life either. You're going to have to, if you're using this every day in your mouth, you're going to have to replace it at some point. It's like the tires in a car. The more you wear it, the more the rubber's going to wear down, and it's going to need replacing at some point. And they've got to take that responsibility and understand that as well. And so that's really key. So the Americans are really good. Like North Americans are fantastic at this. When someone gets a denture, they don't tell them it's going to last them 15, 20 years. They go, you have to replace it in 3 to 5 years. They're really good at that, because you're putting it in your mouth. It's disgusting. Like, they say that, your mouth more dirty than your backside. Like, and you put that every day in your mouth for 5 years, and you think you won't replace it. It will need replacing, like even from a basic hygiene perspective, and it will wear and tear over time. It can be with some patients, it'll be under significant forces. So I try and preface it with like, look, you should change it in 3 to 5. You should realistically look to have enough in the background, park a little bit away every so often, so you can replace it in 3 to 5 years' time. Just for good hygiene, if nothing else. How many people have you seen coming with that really tatty occlusal splint? And it's disgusting. Like, it's absolutely putrid. But it's not got cracks. They're like, still good. Like you don't want to put that in your mouth.
Mm.
So that's what I would say to patients. I would say to them, like, look, every 3 to 5 years, you should be looking to replace it just from a basic hygiene perspective. I mean, you wouldn't wear the same t-shirt for 5 years. You wouldn't do it like on the trot every single day, or the same sneakers or anything. So let's just get realistic with that.
Yeah.
I think analogies like tires or sneakers are a really easy analogy to use when it comes to talking about replacing. When it comes to testing, I can be very honest here, and maybe it's not the best way of doing things, but I certainly want the one objective post post appliance test that shows objectively getting better. I don't get them to periodically do it or buy the test and keep it at home forevermore if they don't want to. But what I would certainly say is, as you notice changes, if you think things are going off the rails a little bit, then you should really think about redoing it and objectively noting whether it's happening or not. There's no point just coming to see me and going, am I going to, my CT scanner hand says, like, that's just ridiculous. Like, I want an objective test. And that's going to tell me, and we have an actual decent conversation about it. So if they've got the appliance, great. If they haven't got the appliance and they know it's a change, they can just come to the front desk, whether it's hiring it out, a take-home test, or whether it's purchasing one or whatever. They can go home, get a test, and book back in, so we can then look at it and see what's happening. Do they need to titrate further or not? And that's our objective guidance towards it. And then again, do another test and review. But as I said, some patients love wearable devices, and some patients will buy the device straight away and they want to keep it, and they will just like periodically just do it, just like because it's fun, and look at their app and see how things are going. And then that may be an impetus for them to book back in and say like, oh, no, it's a change. Maybe I should book in and see my health practitioner, dentist, whoever, to have a conversation again, see where we're going with this. But it's something that we should certainly, even if not get a test, we should touch on with symptomatically and subjectively where they are every recall appointment. And that's why I love being a general dentist. Like, we can look into all of this. I think I'm right in saying that we're all actually general dentists on this panel. We still have our hands in lots of things, and that's the joy of general dentistry.
Brilliant. I've got one. I'm going to try and squeeze one more question in before our little bonus question at the end, and obviously questions from everyone else attending. How do you avoid losing patients to the referral merry-go-round, Hugh?
I avoid it by trying to keep as much in-house as I possibly can. But that's why, we do the sleep testing, the home sleep testing. And once we've got an assessment as to the level, okay, then it's us who'll do the referral. The other thing is, we have the benefit of an in-house respiratory sleep specialist as well, who comes in every fortnight. Okay, and we've got them in-house to do the consultations, whatever it might be. So wherever possible, we avoid referring out or the referral merry-go-round by keeping as much in-house as we possibly can.
I love that point where if you keep everything in the same location, something as simple as that can really impact the patient experience.
Mm.
Rohit, Alex, you got some additional thoughts there?
I think, these days people are also favoring just, more convenience as well. And, I've certainly had my fair share of patients who become a bit frustrated with the systems, like, oh, I have to go see this person here or this person here. I have to do this here and this here. And, sometimes it just becomes all a bit too much, and then they get frustrated, and then, they don't want to pursue investigation or treatment that could be beneficial for their health. So I think, there is an argument keeping as much in-house as possible actually does benefit patients in that respect, in terms of their health, and just making it, facilitating those diagnostic interventions, those treatments, so that you can make it more convenient for them.
Great.
I would just say, like, I remember speaking to Hugh about this a good couple of years ago, And when he told me about his in-house systems, like sitting there, wow, like you've really got it all sussed. And it was amazing. But I agree with exactly what you're saying. You got to keep as much in-house as possible. But it's funny, that's what got me onto the good sleep. One of two factors that got me onto it. One factor was I was having done the acrylic appliances for a long time. I found that there were a lot of they were really bulky. I remember I learned how to do them by making one myself, and I'm a gagger, so this was back in before I was doing even like scanning and stuff. So this was I don't know I was about like 7 or 8 years ago, and I was gagging on the impression material. Then I was putting this big bulky acrylic thing in my mouth that I got made for myself, and it sucked, and it was not a good scenario. And then I found with patients often the wings would break on them where the metal and the acrylic was put in there, and the adjustable aspect with patients with large bite forces and they're being opened up and with the bigger bulk appliance to break the thing. So I was looking for a nylon device, and that led me on to good sleep. And I had that conversation with Greg, and I wanted to give it a go, and then that led to the good sleep test, which was being developed at the time, and that's when it was that penny drops moment, that ability to actually just facilitate an initial examination, ability to facilitate a patient just seeing the value and opening their eyes to the possibility of what might be going on, how this might actually be one solution. Now, this whole idea of Occam's razor is there, where sometimes the simplest explanation that ties lots of things together is most likely to be the correct one. So this one thing can tie up multiple things that we think are unrelated. And so it was a great way to keep the patient in house, but rather than lose them in that rigmarole, that roundabout. Do it in house. It's cheap and easy. Lower that bar, lower that hurdle, and get them over the line, see what's going on, and then they see value in the benefits. So I think that's what having a simple take-home test allows, as we've alluded to earlier with the earlier questions, allows you to do that, and that keeps your patient in the practice. But I think also having your teams clued up, like Alex and Hugh both said, having like members of the team aware of everything so they can also guide the patient, help the patient see value. Because sometimes the patients won't be talking to us, they'll be talking to our team members. And it can't be a case of like, oh, I don't know. Because that just tells the patients that you guys don't really do this. You don't know much. This is not what you deal with. This is something you're clued up on. They think that you're not the people to speak to. So I think if the team's educated, you raise awareness, you can lower the bar for patients who are skeptical or whatever, unsure, don't want to go through the rigmarole running around, they're very busy. Come on, look, let's do a simple take-home test. Let's just see where you land up. It's cheap, it's easy, it's a couple of nights, 3 nights of like sleep basically. Do a week of tests, like a week of wearing it, get 3 good nights, work it out, get a physician report, it's cheap as chips, and then see where it goes from there. And then if you do need to do something big, guess what? There's something like, yeah, God, there's something going on here, and you think now there's a big concern. Cool, I'll do the bigger test if I need to, or maybe I'll just use a MAS if it's just a simple thing that could solve some problems for me. But then it's all done in house. It's all really simple. So I think that's what we just lower the bar, just introduce these things, have these things in sight. Don't send them away to do more homework because they'll just get lost. It'll just get lost in like life. What am I going to cook for dinner? The kid's got this trip going on. I've got to save up for this thing going on. You've got to strike while the iron's hot, while the patient is keen.
Great. Thanks, guys, for your expertise and your advice with those questions. I think we're going to jump into, we've got about 11 minutes left, so we'll jump into the questions from the audience. We've got a question here from Peter. May I ask the 3 clinicians if they have any preferred protocol to assess nasal obstruction, which I understand should be negligible for effective performance of MAD and or MAD devices, or nasal PAP devices?
I can start off that one, Joel.
Yep.
Yeah, so it's a really good question. At the end of the day, I guess what we're talking about here mainly are sleep-related breathing disorders. And, technically the term is sleep disordered breathing, but there's some authors that have suggested it should be breathing disordered sleep because it's the breathing that causes the sleep disruption and the microarousals, etc. So, and anything that's going to cause nasal obstruction, super important to assess. You can ask some simple questions, but there is actually a It's called a nose score, nasal obstruction symptom evaluation, that you can use, and I use it on occasion if I feel like I want something just a bit more objective, particularly if we're thinking about going to an ear, nose, and throat specialist or something like that. So that's one thing you can do. But some sleep studies as well also have, Joel would know more about this than me, but rhinomammalometry, so you can actually detect nasal airflow from that as well.
Yeah, rhino's a pretty good way. I mean, though, you can pick up a rhino for like $1,000, and the test takes about 20 seconds. So you could easily use that in practice as well as a dentist.
Yeah, look, that's a really good question. And yeah, with MAS appliances, especially some of MAS appliances, you're pretty much closing off mouth breathing and encouraging breathing through the actual nasal passages. So and that's why I suppose in our particular case, we always do a CBCT scan to assess the actual overall airways and the nasal passages. And, if the patients say, look, I really have a lot of difficulty breathing through my nose, or there's some form of nasal obstruction, or especially if you see it on the CBCT scan, okay, I will often say, well, I think it might be an idea to let's see an ENT first to see if we can clear those nasal passages before we go down this particular route.
Hugh, can I ask you a question quickly about the CBCT? When you do that, mate, are you getting a report from a DMFR, or are you using a software to help you establish that, or is it built in your system?
WA you have to, don't you?
Yeah, WA we have to. Yeah,
Yeah.
I know. I don't think every state does that. So I was really intrigued from a kind of a Australia-wide thing. How you do it?
For assessment of airways, no, I don't. I do the assessment myself. I do a volumetric analysis, and again, I look at the CBCT and the nasal passages and so forth.
Does your software tell you that, or?
Well, the volumetric analysis software will, yes. It will.
Okay, excellent. Sorry.
But yeah, look, I just look at the scan myself and say, yeah, we've obviously got other issues here that we should also involve, say, an ENT or a specialist to have a look at it as well. And I give the patient the CBCT on a USB with the viewing software and write a referral and send them off, and then wait until I get a report back.
Cool.
Yeah, and knowing full well that if I'm going to refer to an ENT, well, we don't need an OM, if it's a maxillofacial radiologist or radiologist report on it, because they're going to look at the scans themselves.
Cool.
So the next question is, how long does it take to see results after starting with a dental sleep device?
I think it goes back to what Alex was saying, doesn't it, about like what their goals were. If they're looking about their, concern about their hypertension and cardiovascular risk, that's going to take time. It's not going to happen overnight. Took a lifetime to get there. It's not going to happen like that. But when it comes to things like, quality of sleep and tiredness and things, you can notice quite quickly, very quickly, in fact, benefits. So quality of sleep can change rapidly. Alertness during the day can change rapidly, but chronic disease changes, that's going to take time. And there are obviously like multiple risk factors and things, of course, that we should also be considering, lifestyle advice and so on. So realistic goals are key. There are things that we will see quick changes on, and there are things that will take time to come about.
I must admit, I've been pretty surprised at times, patients, especially when I first started in this sort of treatment, in that, patients come back in that first week and go, I'm not making this up, let's say, you've changed my life.
Yeah. So true.
And you go, wow, okay. So, and to be honest, I would say probably the large percentage of our patients, 75-80% would see results from a sleep point of view and cessation, the snoring point of view, and reduction in OSA within the first 2 or 3 nights.
I've got to add, you could be saving someone like hundreds of thousands of dollars, because divorce is expensive. And so the amount of people that get back into the rooms with their partners and actually start having a functional relationship again, I know it's a bad joke, but it's reality. Like the amount of patients, and I'm sure the other guys on the panel will all attest to this. the amount of people who's coming are like, oh my God, I'm sleeping in the same room as my partner. And I think, Hugh, you already said it once. You mentioned it already, I think. But literally, I have patients who's come in and say, we can sleep in the same room again now. Yeah, that's big, like intimacy in relationships and psychological well-being, all those things are important.
It's not every patient, but when they do come in like that, you go, okay, great. I've actually achieved something here.
Yeah, it's massive benefit.
Yeah.
Not to be the pessimist here, but on the flip side, some patients can take a while to get used to, let's say in this case, mandibular advancement splints. So we know from Danny Eckert's research out of Flinders University that some patients have a lower arousal threshold. That's one of the kind of endotypes or endotyping that we're talking about now. Particularly seems to be more females. So those type of patients might be more sensitive to kind of anything going on during their sleep, and having something foreign in their mouth might be one of those things. So some people just need a little bit more time. But I think, in my experience, just providing that reassurance that, everything's going to be okay, being there for any follow-up and advice, I think can go a long way.
Brilliant. We've probably got time for one more question. So might any of the clinicians have prior experience with Alan Moses times slant registration techniques that use manual muscle testing? Any feedback, please?
I can very quickly say I've heard about it, I haven't used it, and I think Alan Moses actually prefers like a monoblock appliance, which is sort of against the guidelines from the American Academy of Sleep Medicine and Dental Sleep Medicine, where we're using, dual block exclusively now, duo block. But no, I don't have any experience with that technique.
Sorry, out of my league.
All right. Well, we're gonna wrap it up. If anyone would like to get more information, or maybe you have some other questions that you didn't think of tonight, please send them to hello@goodsleepco.health. We'll send a follow-up email anyway, just with our details, so that you know where to find us if you have questions. Really appreciate your time, Alex, Rohit, Hugh. Always a pleasure. Some good back and forth there, and some really insightful information on how your practices work and how you all think, which I think is almost as important. We'll touch base again soon, and have some more webinars coming up in the near future. Thanks everyone for attending.
Can I just say it's been an honor and a pleasure to be on this panel with you guys. Well done.
Likewise. Thank you.
Well done, Joe.
Thanks, everyone. Yeah, it's been great.
Well done, fellas. Thank you.
Thanks, Nick. Thanks,
Okay.
Joel.